All right, good afternoon. Thank you all for joining us for today's Michigan Valley Collaborative Health and Action Work Group. Christy Degner and I, Chelsea Andrews, are the site engagement coordinators for MVC, and we look forward to facilitating this work group today. In recognition of National Safety Month, today's work group features a guest presentation by Adam Novak, Director of Safety and Quality at the Michigan Health and Hospital Association, known as MHA Keystone Center. Go back. Adam manages all aspects of the MHA Keystone Center patient safety organization and oversees the development of patient safety culture improvement efforts across all departmental projects under the umbrella of high reliability. Adam led the design and launch of the MHA Keystone Center Speak-Up Award, a proven tool to promote culture and reduce costs and harm in healthcare. He also spearheads the MHA Workforce Safety Collaborative, maternal health, hypertension, and diagnostic error reduction efforts. Adam currently serves as an editorial review board member for the peer-reviewed journals Patient Safety and Journal of Healthcare Risk Management. Previously, Adam coordinated the implementation of the MHA Keystone Center patient and family engagement and pain management programs. He also coordinated efforts for the CUSP for MVP-VAP, an agency for healthcare research and quality initiative to implement evidence-based best practices to prevent ventilator-associated pneumonia in 38 states, Puerto Rico, and Saudi Arabia. Prior to joining MHA, he worked with the Ingham County Health Department in Lansing, Michigan on community health assessment, emergency preparedness, and nurse-family partnership programs. Adam earned his Bachelor's of Arts in Communication with a specialization in public relations and his Master of Arts in Health and Risk Communication from Michigan State University. He is also a Team Steps Master Trainer, Just Culture Champion, and holds the Certified Professional in Patient Safety credential. Thank you very much, Adam, for joining us today for this work group. Before you begin your presentation, I'm just going to go over some brief housekeeping items for everyone's awareness. This recording and the session is going to be recorded. Slides and the recording will be shared with work group participants and registrants following the work group. Any questions that you have throughout the presentation can be shared in the chat, and we'll be happy to address them as available, or you can hold them until the end, and we'll be addressing them in the open discussion afterwards. We do ask that you complete our post-work group evaluation survey. Your feedback is very important to MVC to ensure that we provide the most applicable topics in our engagement opportunities. The link will be provided in the follow-up email following the conclusion of the work group. And with that, I'm going to stop sharing, and Adam, you are welcome to share your presentation.
Great. Well, thank you so much, Chelsea, and good afternoon, everyone. Sure. Okay. Does that look good?
Looks good. I see the PowerPoint currently.
Okay. Is it in presentation mode?
No, it's on the standard screen, the edit screen.
Let's see here. Let me try this.
There we go.
That
looks
good?
Great. Yep.
Okay, great. Thank you.
Nope.
Good afternoon, everyone. So again, my name is Adam Novak. I'm the Director of Safety and Quality at the MHA Keystone Center, and I help to oversee our patient safety organization as well as running the MHA's workforce safety efforts, just kind of under the umbrella of safety. So I am privileged to be able to do a presentation today on safety culture and adverse events in healthcare and kind of the intersection between those two things, as well as, so we're going to look at patient safety and some components of staff safety and how sort of a foundation of a culture of safety is really imperative to safety and quality in healthcare. All right, so What is safety culture? Well, according to the Agency for Healthcare Research and Quality, or AHRQ, and AHRQ, just for your information, oversees the federal patient safety organization program. So every 3 years, we go through an audit process with AHRQ to maintain our listing as a federally certified PSO. So AHRQ, if you look it up on their website and in their literature, says that basically patient safety culture, or safety culture in general, refers to the values, beliefs, and norms that are shared by healthcare practitioners and other staff. And so, in essence, what this means is the degree to which healthcare staff, whether they're clinical, non-clinical, administrative, what have you, the degree to which they agree or disagree on their beliefs and values about safety. So the common sort of sentiment is, this is just how we do it here. This is kind of how it is. And then you ask, well, why do you do it? Why does everybody, why does everybody do the timeout before a surgery? Why does everybody scan the barcode, double check medications before being administered? That's just how we do it. That's part of the culture. You don't really have to be told to do it. And the cool thing about culture is that when it's thriving, it can survive a lot of turnover. So new staff coming in with a fresh set of eyes can kind of be absorbed into that culture if it is thriving. And so why is safety culture important now that we know, generally speaking, what safety culture is? There's a number of different reasons. I've put here on the slide kind of a high-level look at some of the major ones. But basically, again, keeping in mind the definition of safety culture, if we align those beliefs and attitudes of all staff so that they're kind of all flowing in one direction in terms of how we conduct quality improvement, safety improvement activities, and kind of getting everybody on the same page, it opens communication channels between staff. We know that there's a lot of issues. For instance, I put here as an example, bedside shift change, communication and handoffs, communicating with patients and care partners as well. And so being clear, being succinct, and being efficient at communicating with other team members and other units too, if it's unit to unit, can really greatly impact safety outcomes. When we think about the concept of psychological safety, or essentially, are you comfortable speaking up? Will you stop the line, quite literally, if you have a concern with safety or quality? If a nurse is about to administer a certain type of medication and scans the barcode and everything checks out, but then she just stops and thinks, well, I don't think this is the correct medication. Is that nurse comfortable contacting the pharmacy department or going to another nurse, the charge nurse, or maybe consulting with the attending physician or the resident, and saying, hey, we need to kind of reevaluate this and confirm that this is the correct medication. So that idea of psychological safety is a very good sign of a thriving culture of safety, because it means that others within the group, other staff, leadership, et cetera, are encouraging that behavior and really allow it to happen, and that there's that feeling that I can say something and I won't be reprimanded for it, which is crucial. So again, not being afraid to speak up with concerns, having a common understanding. So learning from adverse events is really the bread and butter of what we do, of what I do at the Keystone Center and within our PSO. And so that kind of goes hand in hand with psychological safety as well. We have to have staff who feel safe reporting adverse events, whether it was a near miss that didn't quite reach the patient, or an incident that did, whether there was no harm associated with it, or whether it was catastrophic harm or even death. We need to learn from all of these adverse events. And so speaking up and reporting and having that becoming a common part of the culture is also crucial. And so safety culture improvement can really go a long way in affecting that. And then physical safety for staff. So I mentioned briefly at the beginning, and I'll show some slides in a little bit here, on staff safety and kind of how culture can influence that. And so just an example down here, supporting a zero tolerance for violence, whether it's physical violence, you know, hitting, kicking are certainly big ones, but a lot of people don't think of reporting a small scratch or yelling, something that's non-physical, but being sworn at, being yelled at, berated, which happens all the time and has frankly gotten much worse throughout COVID. And so there's certainly a staff safety component to safety culture. So now that we know what safety culture is, how it's defined, and some examples of how it can influence certain components throughout the spectrum of care, let's talk about how we measure safety culture. And this is really a cool part. I'm a very data-minded, data-driven, geeky kind of person. And so anytime I can get my hands on data, whether it's anecdotal data or, you know, aggregate quantitative data, I get really excited about that. And so there's two main tools that we utilize at the Keystone Center within our PSO. And there's certainly more tools out there, but these are two validated culture measurement instruments, if you will, that we utilize. And there's some slight differences to them, but in essence, they seek to measure the same thing, those attitudes and beliefs about safety. And it's broken out into various domains. We'll look at a few of those in some example data charts. But the first one that we administer to our PSO members every 2 years is called the SCORE survey. It stands for Safety, Communication, Operational Reliability, and Engagement. This is a proprietary tool that is owned by a company called Safe and Reliable Healthcare. They were recently, I think within the last year, purchased by Vizient. So I think it's Vizient Safe and Reliable Healthcare. And this is a tool they created. It's been scrutinized by a lot of statistical analysis, so it is highly valid and reliable. And then the second tool that you may be more familiar with is the ARC SOPS or HSOPS, Hospital Survey on Patient Safety Culture. And they do have medical office surveys, and they have supplemental question sets for looking at, you know, diagnostic errors and different things that kind of feed into culture. But the ARC survey is freely available, so it's not proprietary. Anybody can go to the ARC website, you can download it, you can use it, you can sort of pick and choose different questions, even though it's not really encouraged because it could affect the validity of the survey. But so those are the two primary ways we measure culture. Every 2 years, we administer this survey to any of our hospital members who are interested in it. We have 136 hospitals currently in our PSO, and I would say roughly half of them survey. Sometimes they use their own tools, but those are the main ways we measure culture. So now to look at some data, and I pulled a few different slides here, and this is just the tip of the iceberg of the data we have. I mean, it is insane how much data we collect in these culture surveys. There's roughly, in the SCORE survey, roughly 80 to 85 survey items. So it is a little burdensome, and that's why we have to be careful and only administer every couple of years instead of yearly, because there is survey fatigue associated with these for sure. So I'm just showing kind of a brief snapshot in these cool little circular data images, data charts that are generated with our data management platform for our culture data. And each one of these slides, I've highlighted a box that sort of jumped out to me in terms of some differences between the demographics that we're looking at here. So first, we're going to start with race. This is data from one mid-sized system in Michigan, and they did collect race data, and they did collect gender identity data as well. And the details of it, kind of the categories we have for each of these, is still fairly crude. We're looking at really expanding it to capture more of that information, but this is what we have at least as of this year. So you can see what we're looking at here are different survey items with their domains listed in all caps. So if we look at the upper left, improvement readiness, that is one domain. And within improvement readiness, there might be 6 items, 6 questions. They're not really questions, they're statements, but 6 survey items or 10 survey items, or some of these only have 3. And that is what's listed below it. So if we look at improvement readiness domain, and this survey item is the learning environment effectively fixes defects. And you can see 80% responded positively to that. So essentially what these surveys have is each item, there's a Likert scale response option. So it's 5-point Likert scale. It goes from strongly disagree, moderately disagree, neutral, kind of like I don't really know one way or the other how I feel, and then strongly agree, or excuse me, moderately agree and strongly agree. So that's the spectrum. And the percent positive are people, staff, who responded strongly agree or moderately agree. The yellow is the neutral people, and the red is the moderately disagree, strongly disagree. So you can see here, green is good. We want more agreement with these items. And I will explain a little bit, won't go into too much depth, but a little bit about negatively worded versus positively worded questions. But for our purposes here, green is good. That's basically all we need to know. So we're looking at, these are the responses within that system of staff who identified as Black. And I'm pointing out here growth opportunities. So I have the feeling that I can achieve something. 68% of the staff who took this survey, who self-identified as Black, responded positively that yes, affirmative, I feel like I can achieve something here. Now, if we move to this next slide, same domains, we look at the data the same way, but now these are staff who identified, self-identified as white, and you can see the positive is higher, not tremendously higher, but higher, 68% positive for staff identifying as Black, 73% positive for staff identifying as white. Now, if we look at these same domains, now split out by gender, again, self-identified on the survey, and there was an option for I'd prefer not to say. So this is just those who said, I identify as a male on this slide. We're looking at burnout here, and this is pretty concerning. Just in my experience, looking at culture survey data, having 31% report positively. So burnout climate, when people in this work setting are, people in this work setting are burned out from their work. So it's, what is your perception of the burnout level of other people? That's burnout climate. Not shown here is also personal burnout, a different domain, which looks at what is your perception of your own level of burnout? This is, what is your perception of others' burnout? And so what they're reporting is that within the male group is that only 31% said strongly agree or moderately agree to that item, meaning there's a lot of burnout going on. So roughly 51%, more than half, responded negatively to this. About 20%, 18% it says here, were neutral, kind of like, you know, I don't know, some days I come in, I feel okay, other days I'm super stressed out. And a lot of times these questions will include a time frame on it. So within the last 2 weeks, you know, how many nights did you get at least 7 hours of sleep? Or did you have to skip meals because of work? Did you have to cancel personal plans because of work? Kind of like this work-life balance domain down here. And something I forgot to mention, if you can even see it, the little tiny percent number inside the inner circle, at the bottom of that inner circle, that is the percent that it either improved or went down, got worse since their last survey 2 years ago. So you can kind of trend the data over time to see, okay, we got 4% worse here, we got 3% better here. So this is male, 31% positive for burnout climate. When we look at those who identified as female, 27% positive. So again, a little worse. The male staff members, even though they're both bad, if I'm being really honest with you, the male staff members reported less burnout than their female counterparts. And then, interestingly, and this actually made me kind of sad when I looked at this, because this is all fresh data from this year. We looked at those, and it's a small denominator, but large enough for us to be able to generate these data reports. When we look at those staff members within that system who identified as non-binary, right? So we have male, female, non-binary. Just look at these scores. I mean, this is pretty horrendous. When we look at burnout, 13% positive. Again, smaller denominator, but only 13% said strongly agree, moderately agree to the burnout question. And you will notice there is a larger proportion of neutral as well. That's also noteworthy. But this is the type of data that we're looking to collect more, because even though it's bad, these are the tough kind of discussions, conversations, sort of the cold splash of water that hospitals and health systems and anybody in healthcare really needs in order to then drive change. We have to be data driven. And so it gives us an idea when we look at, just backing up here again, when we look at male, female, and then those in the non-binary category, this gives us a way that we can approach these conversations with sort of the toughness of data, the concreteness of data. So I want to pivot a little bit. We talked a lot about culture. I want to pivot a little bit to adverse events in healthcare, generally speaking, and then we'll sort of bring it all together in terms of how they sort of coexist and what the implications are for that. But an adverse event in healthcare, loosely defined, and you'll find different definitions from different organizations, whether it's, the Joint Commission or NQF, National Quality Forum, or CMS or something else. But an adverse event, basically, at the most general level, is anything that happens or could happen, including an unsafe condition, like a puddle on the floor that hasn't been mopped up, and somebody could slip and really hurt themselves, all the way to, a surgical site infection. Anything that happens or could happen that you just don't want to happen. It's something that could happen or did that was bad, that was an outcome that was unintended. And so examples that I've listed here, and this certainly is not an exhaustive list, but examples here include medication errors. For those of you familiar, there's many, many ways that stuff can go wrong with administering medication: the wrong med, the wrong dosage, the wrong patient, the wrong time, the wrong route, and so many places along the process, from dispensing the medication by pharmacy to putting it through the tube system, or delivering it somehow to the floor or to whomever needs it, whatever provider needs it, to administering the medication. There's multiple points where it's possible to fail, and one of these things could go wrong. So medication events are actually the top type of event that we see reported to us. We have about 1.25 million event records over the last, we became a PSO in 2009. So we've had a while to collect this data, but that's consistently the highest proportion of our coded data. And then we have things like patient falls, we have pressure injuries. We saw both of those go up throughout the pandemic. Again, surgical issues, so wrong site, wrong procedure, wrong patient, getting a surgical site infection. There's fires in the OR, there's retained foreign objects. I mean, there's all kinds of stuff. So we're collecting and amassing all of this data and analyzing it and figuring out how we can drive change with it relative to actual adverse safety events in healthcare. Just to provide you an idea of some of our data, I recently presented this at our PSO annual meeting in 2023, earlier this year in May. And this is looking at just our 2022 data. So for that calendar year, this is kind of the breakdown. You can see the top category, almost 50% of our data is classified as other. Now, it doesn't mean that it's not a fall, it's not a surgical related issue, it's not a device issue, HIT, health information technology, but unfortunately, this is the catch-all. This is sort of the junk drawer for safety events, that everything that isn't readily or easily able to be classified as one of these other main buckets just kind of gets dumped into. And I'll show you on the next slide, we are able to kind of pull that category apart, but it's something we're really working on. So then when we look at the rest of the 50% of the data, this is how it breaks down. I mentioned our medication events typically range from 15 to 20% of all of our data submitted in terms of the proportion of the data. Falls typically range between 10 and 15%. And then moving down the list, blood or blood products. So this could be a lab related event. A specimen expired, there needs to be a redraw, they were testing for the wrong thing, specimen is mislabeled, it got lost, all kinds of stuff happens there. HAI is a big one. Surgery or anesthesia, I mentioned device or surgical supply, we run into a fair amount of those year to year. And then moving down the list, it gets lower and lower, all the way down to VTE, which is a very, very small proportion. Typically every month we only get one reported event across our membership, or maybe a 1 to 5 and sometimes 0. So that is very, very low, which is a good thing. So now if we're pulling apart that other category, so just to back up real quick, the 49% that's other, this is some of our members are able to subcategorize their data. Some of them don't, but I would say about 35% of those other events. So if you bear with me here, 35% of the 49%, kind of going down a rabbit hole here, is what we're looking at here. And so you can see there's some overlap, treatment or procedure, testing, and then we get into kind of some less common ones that are submitted when we look at, disruptive behavior, care coordination is certainly a big one, diagnosis related. So diagnostic errors are huge. And I think there's a lot of room to reclassify those events. So this is sort of the general breakdown of what we're looking at with our adverse event data. We also look at serious safety events. That's a subcategory of all of the data. Basically, and again, you'll hear different terms for it. Serious safety event, NQF refers to them as never events. It should never happen. Sentinel events, Joint Commission has some different wording, but they all basically mean the same thing. They're events that ended with more severe harm to the patient. So for our purposes, we're looking at only events across all harm types that resulted in moderate harm. And you can see the definitions here, I won't read them, but moderate harm, severe harm, or death. And those are considered more catastrophic. Obviously, death is catastrophic, but certainly moderate and severe harm can be as well. And so this is just our data plotted over, a few years. And one of the ways we examine this data is interesting, and we're kind of always being curious when we're looking at our data reports. But you can see moderate harm went down considerably in January of 2022. We saw some interesting trends change throughout the pandemic as well, certainly when it started kind of in 2020, early that year. And then looking at serious safety events by category, the one thing I'll point out, so again, another huge proportion listed as other, but if we look beneath that, medication events and falls have a real high proportion of moderate harm. They lead to quite a bit of harm. And then surgery or anesthesia, you'll notice, has a high proportion of death events, which, a lot of that, it's a dangerous operation or one that could have negative outcomes. Certainly anesthesia has the potential for great harm, especially if it's a special care patient or a pediatric patient, and dosing is very important. So there's all kinds of things that can be attributed to this. I mentioned things like retained foreign objects, which if they're discharged after the surgery and it wasn't caught, that can lead to really nasty infections, and the patient can go downhill very quickly. So this is really just a crash course in what our adverse event data looks like. And then I threw this slide in here. This is just a ratio we keep an eye on. Our serious safety events, so again, moderate, severe, death, versus our no harm and mild harm. So basically the other harm types. And this is typically what you see. It's vast majority no harm and mild harm, which is good, almost 98%. And the other good thing as it relates to culture of safety is that the more no harm, the more mild harm, the more near miss data that we get, the better. It really indicates, even though it sounds counterintuitive, why would an uptick in reporting of these event types be a good thing? And the reason is we know that there's widespread underreporting of those events that are near misses that don't lead to harm. And a big reason is that staff are, they're stressed, their time is stretched, they don't have resources. They figure, well, there was no harm with this event. We caught it, nothing bad happened, so I'm not even going to fill out a report. It's not like somebody got hurt, but a lot of learning, and you can see 98% of our data falls into those categories. A lot of learning comes from that. And it goes back to that idea of psychological safety, that indicator of a good culture of safety, because if staff feel safe reporting and speaking up about events that it's easy to just kind of brush off and say, I don't really have the time. Nah, we're not really going to learn much from it. I won't even report it. Like, no one's ever going to know. If they still go out of their way to report it, that's what the culture is all about. This is what we do. We report everything, every single event, unsafe condition, anything gets reported, analyzed, and we figure out how we can steer clear of this moving forward. So we talked about culture, kind of gave an overview of the major harm types that we see in our hospitals, primarily acute care hospitals in Michigan and a handful in Indiana. And I do provide the references for this slide on the last slide of this presentation, which it sounds like will be sent out to you, so feel free to reference any of this. But these are just a few things that we found. Mostly these came from peer-reviewed articles. There were actual studies done. And just to read through a few, higher levels of safety climate in one study, or safety culture, but safety climate is one domain, are associated with lower 30-day readmission rates. And as you probably all know, or many of you know, readmissions are huge if patients are discharged when they shouldn't be, if they're not given appropriate follow-up, if they're not being connected to their primary care provider, or they're not getting the instructions on how to take their medications and how to, do wound care and different things. That can definitely come back as a readmission, which is not good. Another study found that there was a 10% decrease in overall culture scores, 10% decrease in overall culture scores are associated with hospital mortality being 1.24 times higher. So you can see how as one increases or one decreases, the other can increase with regard to safety culture and an outcome. Another study, for every 10%, similar to the previous bullet, for every 10% decrease in this study, it was looking specifically at safety events in an ICU. For every 10% decrease in the ICU safety climate scores, patient length of stay increased 15%, which is astounding that there's that level of impact. And length of stay is a huge risk factor for all kinds of issues, for developing a pressure injury or having a fall, or you're just exposing yourself, getting an infection. having a medication event if you're continuously having medication dispensed to you. So that's huge. And then ultimately, just across the board, if you look at a lot of research, better culture is associated with more speaking up about concerns, which leads to better patient outcomes and lower costs. And that last bullet comes directly out of some research we did back in 2019 that was published in a peer-reviewed journal, looking at our Speak Up award program, staff recognition program, doing a crosswalk analysis between that and the types of harm being spoken up about and prevented, and the costs associated with that are now not being incurred because somebody spoke up, as well as an improvement in safety culture. So it's all interwoven. It's really quite interesting to look at. So now pivoting a little bit to workforce safety. So we just talked about patient safety, but workforce safety is always right there. And when we talk about workforce safety and why it's so important with regard to patient safety, I like to use this example. The first bullet is that if you've ever flown on a commercial airline traveling anywhere, you know that as you're taxiing to the runway, you get that safety briefing, right? The quick one, nobody ever pays attention to, where it's like, here's how to buckle your seatbelt, here's where your water preserver is. Oh, and if the cabin loses pressure, your mask comes down. What do they always say? Always put yours on first. Put yours on before helping a child, an elderly person, another adult, anything. And the reason is you're no good to anybody if you yourself are suffering, if you yourself pass out in the case of an airline and not getting enough oxygen. And only then when you're safe, now you can start to help other people. The exact same thing holds true in healthcare. Staff have to be mentally well, physically well, and that relates to like burnout, to the psychological safety, but they have to be mentally and physically well in order to provide the best quality care and the safest care possible. And unfortunately, this is it's always been a problem, but we've seen numbers skyrocket in different types of staff harm, specifically relating to violence. Across the pandemic, everybody's frustrated. Nobody wanted to mask. You know, there's a million different things. They restricted visitors for the longest time, which is insanely frustrating. And so staff have to be safe, and only then can they truly provide the safest, best quality care. Other ways, again, that culture plays into workforce safety. Enforcing, or a good culture enforces a zero tolerance for violence. So reporting, again, I hate to keep going back to violence, but violence is terribly, terribly underreported in healthcare. And nurses in particular, really the backbone of healthcare in our hospitals, suffer the most. They are assaulted verbally or physically. We saw those numbers go up. I don't believe, throughout the pandemic, I don't believe I included a slide in here, but you can go Google search the most recent data on this, on healthcare, from the U.S. Bureau of Labor Statistics, and it's really frightening. It's really frightening. About 3/4 of all violent incidents that are reported in any field, any industry, are healthcare. The vast majority of assaults happen in healthcare. It's a very dangerous job, which is not how it should be. And that's why we're doing this work and building that culture. But adhering to again, other things aside from violence, proven processes to prevent sharps. Are we all, you know, following those standards? Are we, when we think about patient handling and mobility, are we doing that safely? Are we using lift equipment or movement assistance equipment, whether it's, you know, a sling, a mobile sling, or, you know, a slide sheet or an inflatable, whether we're moving a patient or assisting them up off the floor if they fell, or assisting them in ambulating to the bathroom or somewhere else. And so a huge part times people, staff, aren't trained on the types of equipment, on when to use it. It's not easily accessible. There's just, and then they sustain some type of musculoskeletal injury, which those types of injuries are typically the most severe. They sideline staff. Sometimes they end their careers. And obviously we're in a healthcare staff shortage, so we can't afford that. But just even if the staffing issue wasn't a problem, we can't have staff being injured. And then building individual resilience, that really does change the culture, and the culture changes that. So how resilient are staff to changes, to adverse events that happen, or witnessing an adverse event? It really can have a powerful negative effect many times on staff if they witness a coworker getting punched, which happens every day. And so building resilience, building that culture of zero tolerance, of support, of this is not okay, this is not part of my job, is paramount. And one thing, kind of on that note, one thing we're doing, which is sort of a cool program with regard to the resilience piece, to driving down rates of burnout specific to healthcare workers, is for the last year and a half or so, we've been partnering with Dr. Brian Sexton and Duke University. Some of you may be familiar with his work. He's published a lot of research on 3 Good Things is what it's called. So basically, it's a super simple program that is shown through data analysis time and time again to be incredibly effective at driving down burnout rates, at improving mental health and well-being. And actually, and I don't have this data stat with me, but multiple times as I've spoken with Brian and his team, in their research, they point out that long-term, like 6 months to a year after going through the 3 Good Things program, there was an effect that lasted longer than some medications, some antidepressants. So clinically, it could actually be more effective in certain people than medication. And 3 Good Things is basically, just to explain that, every night you sit down and you talk about or think about or journal about 3 good things that happened during the day. Could be anything. It could be, oh, I went outside and saw the sun for the first time in February, and me and my spouse went dancing, and I enjoyed a walk through the park, or cooked a meal, or saw a friend, or something like that. And if you do that long enough, it has a lasting effect. It's really tremendous. On the left-hand side is a different program run by the same team under Brian Sexton, called Well-Be. This is actually a free program. It's available to any healthcare staff member in Michigan. You can sign up for this. We've included this little QR code here down in the lower left. This program features one 1-hour monthly webinar on topics relevant to improving resilience, building that, driving down burnout and emotional exhaustion. That's another way Duke references burnout. And this program did begin, these monthly webinars began in November of last year, but they run through October of this year. And all of these recordings are available. So if you register, you can go back and watch all of these and catch up. There are continuing education credits associated with each of these as well, even if you go back and watch the recording. So that's really nice if you need a CME or a CNE or something for a certification. And the coolest part is, not only are these topics great, and Brian and his team are so good at delivering the information, it's rooted in data. So before rolling out this 12-month program we're currently in, going from November of last year to October of this year, we did a pilot test basically for 11 weeks. So instead of 12 months, it was 11 weeks. It was one 1-hour webinar per week. And we were able, across the Michigan MHA membership, we're able to recruit more than 5,000 healthcare staff participants. And Duke University did a pre-test, post-test study design on emotional exhaustion, which basically means burnout, on those participants. And what they found is, across those 11 or so weeks, there was a 20-point improvement in burnout which is remarkable. When we later talked to Brian, he said, you know, they were kind of expecting a 5-point improvement, maybe 10, but 20 is just remarkable. And it really shows that this program is effective. And so it's kind of a feel-good program, but it's rooted in data. So again, just backing up, this is the program here on this flyer on the left. Feel free to register anybody you'd like, and kind of go at your own pace. And then this last slide, these were just the references for that one slide that talked about you know, the readmission rates and looking at culture and safety climate. And so just to sort of bring it all together, we talked about safety culture and the importance. It really, we consider it absolutely foundational to everything we do here at the Keystone Center. Without a safety culture established, really trying to tackle safety improvement and quality improvement programs is an uphill battle, big time, because it's not going to stick. People are already burned out. Some staff might be spiteful, or there might be conflicts and communication breakdowns and value misalignment with organizational leadership and the board and the policies and procedures and lack of understanding. So much of this is just interwoven into the fabric of the culture at the organization. So there's that base culture piece. We looked at the different types of adverse event data. So the falls, the medication events, the pressure injuries, and all of that, and looked at some stats and some data on how they're intrinsically linked, how improving culture usually improves outcomes, medical outcomes. And then staff safety, again, culture has to exist for staff to feel psychologically safe, for them to feel mentally and physically well, and to be able to provide the best, safest, highest quality healthcare to the patients, to the community, really, that they serve. And so it's really kind of a neat thing to study. And I've been really lucky that I've been able to study this for a long time and speak with some of the experts out in the field. And we collect all of this data, the event data, the staff harm data, the culture data, through our various tools and methods. And then ultimately, we feed this information back to our members to say, this is what we're seeing, and this is what we recommend you do to improve. But knowing the problem and acknowledging it is the first step. So it's all data driven. So with that, I think that was my last slide. Here's my contact information if you do want to reach out to me at any point, and happy to take questions.
Thank you so much, Adam. Wonderful presentation, great information shared. I'll open it up. Does anyone have any questions for Adam about any of the information presented today or any of the initiatives that were discussed? All right. I don't have any questions. I think everything you presented is fabulous, and I'm really excited to see where this goes and how safety culture seems to advance throughout the next couple of years, especially after the pandemic. I think, like you said, it's foundational to change and quality improvement initiatives across healthcare and the entire field. So, Christy,
Yeah.
even you, Julia, do either of you have any questions for Adam? Great.
Yeah, definitely always happy to, you know, email back and forth or hop on a call, discuss anything, or if you have questions.
Fabulous. Irene has a question. Is there national or state statistics for best practice of percentages near missed to percentage actual events? Do you know of any comparison data available?
That's a great question, and it's very timely because we actually just had a couple hospital members reach out about it, and we're actually, so I don't really have an answer for you, but we're checking around to see if I believe ARC might have a recommendation for that in terms of that ratio. And so I can certainly look into that and can circle back with that information once we find it. But it was honestly just within the last week, somebody reached out to us about it. So we're actively exploring that because we know our percentages, but looking at a recommendation and looking at what others are seeing, we obviously only have data from our hospitals, but even connecting with other PSOs from around the country.
Of course. Thank you. Appreciate that.
Yeah, great question.
Excellent. No, thank you, Kathy. Awesome. Well, I'll open up our other slide deck just to close out the work group. I appreciate everyone's participation today. So upcoming opportunities for MVC engagement, you're also welcome to join us for our upcoming chronic disease management work group. This will be held July 13th at 11 a.m. We'll be discussing care navigator programs. This will be presented by Holly Gould at McLaren Port Huron. And then we also have an upcoming diabetes work group on July 19th at 1 p.m. We will have guest presenters Brenda Gleason and Carly Fundinger from Sure Health presenting on Sure Health's diabetes education program. As always, you're welcome to send any questions or future topic recommendations or requests to the Michigan Valley Collaborative staff at our team email address listed on the screen. Thank you again, Adam, for a wonderful presentation and recognition of National Safety Month. I know many of our members, especially the site coordinators and staff on the call today, have this as a top thing in mind in all of their quality improvement initiatives. So appreciate you sharing your expertise and taking the time to meet with us today. And always in support of the MHA Keystone, appreciate your support of MVC. I hope everyone has a great rest of your day. And thank you again.
Great, thank you.
Thanks, Adam.